All right. So we're going to look at the activated charcoal. Somebody tell me what the indications of charcoal was going to be.
Poisoning.
The indication of the charcoal is going to be a toxicity, poisoning.
Correct. Somebody tell me what kind of poisoning we would use for charcoal. Well, let's say this. What kind of poisoning would we use charcoal for?
Overdose on meds like pain pills, possibly.
Yep. All right. So what about some actions? Well, how is it absorbed to the body? Or how does it take care of the toxicity that's in the body right now?
Like how it interacts?
Yes. Anybody want to guess? All right.
It absorbs the toxins.
Correct. So it absorbs, it binds to the surface of the so like the toxins will bind to the charcoal itself, and it prevents the absorption to the body. Yeah, Mal, it goes into the digestive tract. That's correct. A lot of the times you'll get it in the like the little white container. Everybody's know what I'm talking about, and you got to cut the top of it off. You might want to get a towel or a garbage can or something ready because it's fun. Cool, Robin. I got your message. Um, so it acts also as a laxative. You might want to be careful for that. You may want to prevent that, and just an idea of that coming. Somebody tell me what the adverse reactions are of it, or the adverse effects. I'm sorry.
The side effects is going to be nausea, vomiting, and constipation.
Yup, 100%. So it can either cause substance to move through the GI tract, or it's going to plug them up. So think about that. So is there any precautions to this if you're thinking about giving charcoal?
It doesn't absorb all drugs.
Correct. It looks like we went to the same Google place. What about contraindications on it?
It's unable to protect the airway.
Yep, that's why would you want to do that?
Depends on their consciousness, their level of consciousness.
Yeah, so it depends on what you don't want to give it if somebody's unresponsive. You want them to be able to be. They need to. I mean, if they're altered, that's okay, but they can swallow, breathe on their own. That's fine. But you just definitely want to try to shove it down on somebody that's unconscious. Um, so what's the adult dosage for charcoal?
1 to 2 grams per grams per kilogram.
Well, it's 50 to 100 for a dosing of an adult.
So it's basically, so here's the easiest way to remember it. And I'll tell you this. So for adults and kids, you want to go, it's 1 gram per kilogram. All right. So does everybody know how to convert them from pounds to kilograms first?
In a minute.
I heard the last bit of somebody saying something.
It's been a minute.
Okay. So if you're easy math, if you're 200 pounds, you divide it by 2.2. Basically, you can say it's roughly 100 pounds, 100 kilos, right? So
Right.
in the med side, everything is swapped over to kilos. Yeah, it's confusing sometimes. It's hard. But for the charcoal, you're going to be 1 gram per kilogram for the adult and pediatric. So that's kind of easy to remember if you can just remember the grams, like how much. Okay, I can give 1 gram per kilogram on both of them. Can you give this medication without making a call to med control or just following your regular protocols?
If it's in your protocol.
Perfect. That's exactly what I was looking for. So if it's in your protocol, you can go ahead and do it. If you feel like you just need to make sure, you can always call med control and ask a double question just to say, hey, look, I want to double check on this before I, get going. Just as a hint for you guys, that stuff sits on the shelf for quite a while in our units before we use them, or even in the fire truck in your bag. So if you get ready to give this, you want to shake it pretty well. Shake it up pretty vigorously. Sometimes if you'll put a straw in it, it may be easier for the patient to drink it, but not too many people keep straws on the ambulance. So it's and anytime you give it, you want to make sure you write down, who it is, what time you gave it, what time they started and what time they end, and did any of it get vomited up? Does that make sense to you guys?
Yeah.
All right.
But
So if
Go ahead. Who's
say they're unconscious, I mean, obviously, if you suspect a drug overdose, you don't know if it's an opiate. So would you give both naloxone and activated charcoal?
Well, good point. First off, if they're there by themselves, you're not going to know. If you see a note or something like that, or an empty pill bottle, that'll kind of give you an idea back and forth on which one was given, versus if you have to give naloxone or anything like that. Victoria says, make sure to give them a garbage bag. Yep, exactly. Because they do vomit this pretty regularly. I don't know if any of you guys have ever unwillingly tried this or willingly tried this. It's very, very, very disgusting. So keep that in the back of your mind. All right, guys, I'm going to mute y'all, and I guess we're going to start. If y'all want to mute your mics, and we'll start going from there. But on my end, I have y'all muted, so in case it does swap over, I don't want y'all to think that nobody's listening to you. Yeah, Victoria, it does suck cleaning all those black spots off the ambulance walls, especially the ceiling. It always gets right there on the window, too. All right, let me get to the top of it here. All right. Whoops, maybe if it helps, I click it. All right. So pharmacology. Pharmacology is patient. It applies to the patient assessment and the management fundamental knowledge of medications carried by the. It says the EMTs. Actually, this is Jones and Bartlett's. I think parts of this is in either section of it. So it's pharmacology is the study of medication. We want to make sure you know a base of knowledge of what medicines are on your truck. You have a good understanding. A lot of paramedics, when they go through school, they'll have to do drug cards. I was actually going to try to break it down and show y'all how to do a blank drug card, but I just wanted y'all to do some, study of medication that majority of you basics are going to be able to use. What's going to be at your reach if you get to have to run a basic truck or something like that, you'll be already have an idea. So here's some of the key principles of pharmacology. We'll talk about all this. The cons, the medication legislation, naming, classification. And as you saw, that some of these drugs, if you looked up any, just, you Googling it while you're searching for the information I posted out there, they have some crazy names for the naming and classifications. And some of the ones that we're used to hearing are, generic names instead of the trade name and stuff like that. A lot of your storage and security is going to be basically the same way, behind a locked door. Narcotics are supposed to be kept behind two locks at all times. The way they sometimes say it is they're locked in a safety cabinet on the ambulance, and the truck itself is locked. Sometimes they'll say, well, it's in the medic's possessions, and it's secured on him. It just depends on what DEA classification that you look at. All right. So we're going to hit some of the metabolism and excretion of pharmacology, mechanism of actions, the toxicity, and how the medication interacts within the body. This actually chapter is pretty large, so it's not as big as the one we hit last night on the airway, but I'm hoping that we can get you some good information and not go too deep into pharmacology, because I hope that you all, go further into your career and it gets way deeper from that. So here we go. A drug profile that gives all specific about the drugs, including a pack list inserted, a list of various pharmaceutical publications. So even I know you probably don't see this, especially on the fire side and on the ambulance side, but each time that you order, let's just say oral glucose, it has to come with like a user's manual, not telling you how to use it, but what the drug's for, all the fine prints that, that really none of us ever read. but it's required by law for that to be attached in the packing on the box itself. A lot of times, even here offshore, we'll take them off, throw them away because they're in our way. They don't sit neat inside the cabinet. So that's just part of the rules that they have to do that. All right, so here we go again. Pharmacology, study of properties and effects of drugs and medications of the body. Drugs, chemical agents used in diagnostic treatment and prevention of disease. Medication, chemical substance used to prevent disease or relieve pain. So we take, like, if we're like, oh, that's a, it's a drug versus that's a medication on the street. Well, I think we classify it differently out in the world ourselves. Like, a lot of people will say, oh, those are drugs, as in like street drugs versus medication. But do you see there's a difference in what they're called for? They do have reasons why they're called different later on that you'll see that they go over a few different things. So we'll talk about the dose, and it's the same thing that comes from your doctor. It's the amount of medication they give you, as in quantity. Depends on the patient's size. So let's just say we'll use testosterone for an example. You may get 1 cc every 2 weeks. It's basically of 100 milligrams comes in a cc, or they can give you 200 milligrams every 2 weeks, which they'll have to change your testosterone to 200 mils. So it's all different, but they sometimes will also judge that on the size of your patient. The age is big too, because you're not really going to give somebody a high dose of it, like a young person may get of hydrochlorothiazide, which is a blood pressure medicine, versus what you would give to a elderly geriatric patient. And then what do you want it to do? What do you want this medicine to, to function as? How do you want it to work on the body? That's what you need to know. Like, they may up the dose of it, say instead of saying once a day, they may say take it twice a day. And the action, look at there. You want to know what the therapeutic is of the effect of the intended effect of the medication is expected to have on the body, like nitroglycerin. Do you want to use the paste that is released over time, or do you want to use the pill that's absorbed through the body, or do you want to do the nitro spray? So you need to know all these things when you start talking about how you want it to affect the body, and the doctors will ask questions, and it's always funny. A lot of them don't write the prescriptions in the room. They go out and they, not say they Google it, but sometimes they'll reference on what the correct dose is done for that. So I always joke and ask my doctor, why don't he stay in here and write the script, because a lot of them won't do that. All right. Whoops. Next slide. So the indications, the therapeutic uses for particular medications, like take 200 milligrams of Tylenol, or you'll take 250. Depends on how bad your headache hurts. What do you want it to do? Specific signs of circumstances when they're appropriate to administer the medication. If you're assessing a patient and you're realizing that they're having trouble breathing, and that you want to give them albuterol, well, when would you give albuterol? In the airway part, the breathing part, or the circulation part? What do y'all think? Breathing, that's correct. You want to give albuterol during your breathing assessment, because you're checking their ABCs. You want to make sure that you can help open the airway, and albuterol it's good for that. I have a side story about that, but it's probably not appropriate. It's overseas. They used to call it something else. So the contraindications. Do I want to give nitro to somebody that their blood pressure's bottomed out? No, I don't. They may be having a cardiac incident, but I don't want to give that drug. So that's a contraindication of giving that drug, because it's going to cause that patient harm. It could cause them to bottom their blood pressure out, and then now I'm working a cardiac arrest. That's my fault, because I gave the wrong drug in the wrong time, or the right drug at the wrong time. Specific signs or circumstances when it's not appropriate to administer medication, like we just said. If you hadn't had any positive effect to the patient's condition, if it's not going to benefit that patient, why am I trying to give it? It's not going to work. That's like trying to say I'm going to give albuterol to somebody in cardiac arrest. It's just not going to work. They're having breathing and respiratory problems, but it ain't going to work. So we're not going to give it to them then. What are the side effects? Sorry. Is any any action or other desired than one. Maybe if they say, well, I'm allergic to it. Well, what do? Well, I break out in hives. So, well, that's a reaction, not a like a side effect. And it may occur over even if the administrated properly. Um, Also known adverse effects. Some medications will obviously make you sleepy. They say don't operate heavy machinery while you're underneath this medication. Well, that's because it's known to make you sleepy and they don't want to do that. So they may tell you to take it at bedtime. So here's some of the way drugs are derived from animals, vegetables, minerals, synthetic compounds. A lot of the drugs we get are, synthetics, or they come from all different minerals to make up Tylenol. Not very many anymore these days are made up of animals, just because that's PETA and the FDA doesn't really like that anymore. So you're probably not going to see it. So this is where it starts to get a little deep. I did add a bunch of slides to this presentation because I wanted you to get a better understanding of things. And when you hear trade name versus generic name, I felt like it gave you a better understanding. So this is one of the ones that I started with. So the trade name is the brand name from the manufacturers. So that's like Ford gave the Ford Taurus its name. That is what it was named. So the medication may have many trade names, depends on how many people make that particular medication. Like Advil, Nuprin, or Motrin are all ibuprofen, so different companies make it. So it's a proper noun, so the name is always capitalized. So that's how you can kind of tell if it's a trade name or a generic name. So generic names aren't normally capitalized, so that's how you can understand. So if you'll look, y'all see my pointer right down here at nitroglycerin. So in the generic name, it's usually the original chemical name, and it's often used as the name of the medication. Like nitroglycerin is not capitalized because what is that? Why? It depends on what reason. Somebody guess. Matt can beat me. That's a good one. Because it's a manufacturer's name, and that manufacturer has to originally produce that, and that's why it's capitalized a little different. So all of it is listed in the United States Pharmacopoeia, the USP. That's kind of a big thing out there. You get a lot of your information from there. So the chemical name is precise description of the medication's chemical composition and molecular structure. So here's an example of, so now we understand that why, like, can you imagine saying, oh, I need a acetaminophen D3 6092. No, okay. Can I just get some Tylenol? That's really what it boils down to me. That's what all this states. So if you had that on your prescription or on your medicine bottle, bruh, can y'all imagine how big that would be? The bottle would have to be just to fit all that on there, or how little print that would have to be. So acetaminophen, Tylenol, same thing. It just breaks it down a little bit easier so we can understand it. So prescription meds only, obviously we know, are distributed by a pharmacist, requires a physician order. A lot of times nowadays, thank goodness to technology, we don't have to take the scripts anymore unless it's a certain type of narcotic that they have to have the physical script for, and you have to see your doctor on a regular basis for. A lot of the ones that we get now will go through the internet, and they'll just say your doctor will be like, oh, what pharmacy are we using? And you're gonna say Walgreens on 8th Street. Well, a couple of hours later, you get a text message or an email stating that your medication's ready for pickup. So technology has helped us out. Sometimes it's hurt us. It depends on your interpretation of that. OTC meds, over the counters, those are also important when we're talking about doing a good history taking, a good physical exam, assessment of the patient, because you may be taking care of a patient that what they're taking as an OTC meds may be contraindicated versus what the medication they're prescribed, and they may something may affect their blood pressure medicine. Let's say it's a sinus decongestant. Well, the decongestant on top of a blood pressure medicine can really throw them out of whack. So OTC meds, obviously, we know you can pick them up from almost any little store on the corner. A lot of your prescription meds you can find online. Amazon will send them to you. Here's a good example of Zantac. Ranitidine is a prescription name for it. So this one right here is what? Say $30 versus $80. So you tell me which one you're going to fill out, the Zantac versus the prescription one. I think we're all going to go to the store about OTC. Some places insurances won't pay for it that way, but I'm still going to save the money. Here's just some drug information, some sources you can look up drugs. Obviously, we know the internet because everybody did their homework and we all Googled it, either from your cell phone, your computer, or something like that. So you have the AMA, which is American Medical Association, the Physician's Desk Reference, Hospital Formula, Drug Inserts, and we also have, I'm trying to look for the book that we use offshore. It is, so the current one that I have is Nursing 2020. It's called the Drug Handbook. I can look up every single drug by name, interactions. Same thing I asked you guys to find. It can tell me some side effects, and it also has, they're called black box warning. Some things like this particular drug affects the bone marrow. Whew, that's a lot of stuff. So there's all sorts of books. You can have them at your fingertips too, right there. MacDrugs.com is a really good one. I have one on my phone that I use when I go back home and work on the truck. A lot of times you can search the pill, like, again, MacSaysDrugs.com, that you can type in the description of the pill, if there's any numbers, the shape, the color, the hash marks on there, all that stuff, and it can potentially tell you what the medication is. So having it at your fingertips is really nice, and you can also give you a normal prescription dosage versus what the patients may say that they're taking 20 or 30 a day. Well, that's not in the range. Manufacturer of pharmaceuticals is subject to a lot of laws. A lot. There's, what is that? The USP and the National Formula also keep an eye on them. Several federal laws. The unsafe substance is a really big one. Let's say the DEA has a play in it. The FDA. Of course, there's so much going on right now that it's just very hard to figure out. It says a lot of it is required manufacturers to publish information about the side effects and known potential harmful effects. A lot of time you're not going to get that on your medication. You're most likely you're going to get it from the manufacturer's website of that particular medication. Let's see. It says prohibit manufacturers from making false claims about the drug benefits of the drug. So it keeps them supposed to keep them honest. Let's put it that way. So that's kind of the intended actions of these laws, and plus it kind of regulates them a little bit. So here's a big one. Not on wood there, hint, hint. So the Pure Food and Drug Act of 1906, it protects the public from food, medications, and alcohol beverages that may be mislabeled, poisonous, or otherwise harmful. I actually remember that test from my registry. We're not going to tell you how long ago. I think I've already told y'all. And then the FDA, or the Food, Drug, and Cosmetic Act. It's required drug makers to include warnings about possible side effects. And what's in that particular that cosmetic, some of them may still use some animal fats or certain things like that, but they have to be listed on that particular item. Some places refuse to carry them because they have animal fats in there or some particulates of this animal. So that's another one. Here is the Harrison Narcotic Act, 1914, and then the Narcotic Control Act of 1956. Look, 1956, they decided to make heroin and marijuana illegal. I thought that was a little later in time, but we all learned something. And then you have the Controlled Substance Act of 1970. All these dates are kind of important, guys. remember, National Registry tests you on the DOT standard, not just on your particular state standard. So kind of knowing a broad knowledge of these informations, and there's reasons why we have to go over certain things due to National Registry's requirements, but they put them in here for a reason. So if you have time to go back and look at these, or if you'd like me to slow down and go back over and so you can actually write them down, take some screenshots or whatever you would like, just let me know. But these are the Controlled Substance Act is a big one. Registration, procurement, storage, distribution, record keeping of all these drugs, penalties for failure to comply with requirements. I'm sure a lot of you guys know, but so you've always heard of that friend that does the doctor shopping. Well, I'll speak of my home state, Mississippi. Actually, we have a lot of things wrong with Mississippi, but we have a few things that are good. Is our MBN, which is Mississippi Bureau of Narcotics, actually has a prescription registry. I think a lot of other states have this also. But what it does is it keeps track of how many prescriptions you've had of the same of period of any prescriptions, and where you get them filled out, how often you get them filled out. So if there ever is something that's come up, all they have to do is do a prescription audit, and that's something that's only regulated by them. So it is pretty neat that that's out there, but just hints. Like I said, I'm full of useless knowledge out there. Some of the federal legislation is also focuses on guarantee and standardize of the dosages, so doctors can't just up and say, "Oh, central part of Mississippi, Chase." So they're trying to they're trying to standardize the dosages so the doctors can't just write, 100 milligrams of this or, whatever they want to choose. There's a particular amount that they can write, and if it's anything that looks crazy, the pharmacy can punt it back and say this is not normal for us to see. For drugs to carry a USP label, the amount of active ingredients must be 95 to 105% of that stated on the label. So that's very important for the USP to take that into common, to look at us, to keep them, like I said, keep them checked. Here we go again with some other abbreviations. We know what the FDA, we know what the DEA is, the Public Health Service, and the FTC. Those are common names that we're kind of used to hearing, so it's not like it's one of those everybody's trying to figure out what they are. I had to look at the clock real quick. So here's some of the approval process. We're on the right, yeah. Commercialization process takes very long years, if many, unless it's pushed through by the federal government. Sometimes they're given different waivements on that. All new drugs must go through an animal study, clinical trials, and human trials before approval. Like I said, sometimes those are given waivers, and those aren't strictly followed. They're kind of given the old green light to wave them on through and to speed that process up. I read a big long case study a couple years back, and it got started in the early, I think it was like 92, 93, and they finally didn't get FDA approval until like 2006. So it's a very, very long process to get that medicine out there. Here we go. Breaks it down right here on the clinical trials. So you have phase 1, new drugs is tested in healthy volunteers. You'll get either the regular medication, you could get the placebo. So they have that baseline of what to choose and what not to go on. And the participants don't know what they're taking. They know they just given the same drug on certain dates of every single time. Phase 2 is performed in homogeneous population of the patients. Phase 3 is drugs are made available to a large group of the patients. And phase 4, the application for the FDA approval to the drug market. And that's after a huge peer study. You'll get, I don't really read a lot until it becomes to the peer studies. And then what peer study actually does a review on there gives you a better understanding of what medication's coming and what's the good parts and the bad parts about it. So the drug storage and security, so that's the reason why they have to be behind locks and keys. Y'all notice at like Walmart, Target, they have the big, I call them the burglar-proof bars that roll down every day. A lot of your pharmacies now are having Triple doors, steel doors also put on onto the building to keep anybody from breaking in during the evenings. Sometimes they'll have both fire exit doors on the back, but in the evenings they'll shut a big, like I call it, the vault door to be kept from broken in at night. So yes, it's very expensive, but there's certain rules and regs that they have to follow to keep the controlled substances, just and to keep their license. That's kind of one of those things. Expired control medication must be destroyed. It's got to go to a particular place to be destroyed. You can't just walk out back and start throwing it on the concrete or pour all your pills into a bucket of water. It's just there's certain rules and regs that you have to do. Specifically on the ambulance, a lot of times they'll try to rotate, like if they have an air med division or a critical care division, they'll try to rotate those medications inside the company and get their most bang for the buck so they can use the medication within a certain period. Prime example, I know one service that if it's at a slower station, within 30 days of it expiring, it has to be moved to a frontline critical care truck, so they're not wasting any money. They try to rotate it out pretty well. Here's another thing, the potency of the medication. Sometimes you'll get if y'all have ever seen it, you'll have certain meds hung in the hospital that have to have a very dark plastic bag over the IV bag because it is light sensitive, and that's a big issue for them. Light exposure puts a short shelf life on the medication, so they'll cover it. Temperature, a lot like the flu vaccine, it's got to stay in the refrigerator, it's got to stay cold. So that's another point. I think the COVID vaccine also has to stay at a certain temperature. We talked about the light, the moisture. Same thing for pills. You don't want the pills to get exposed to moisture because they'll start breaking down, or they'll harden and they'll never, just break up. Victorious, I keep getting kicked out of class for some reason. Sorry. You just didn't know I had that button. I could just kick out whoever I wanted. That's what's happening to you. The shelf life is also the exposure. What time is is the medication going to expire within a certain amount of time, and they'll just rotate enough stock basically. Same thing they do in grocery stores. They'll put the one that expires the most to the front, and the one that with the oldest expiration goes to the back. It's the same thing when they start using shelf life in pharmacies. Exposure to air. I'm just trying to think of a medication that has the air exposure. I can't really think off the top of my head. I'd have to Google that one for a good example. Somebody Google that one for us real quick. What medications have exposure to air, or break down when they're exposed to air? Y'all let us know. We're gonna keep moving. Pregnant patients, you have to be very careful on that one. So prime example, I'll use this one so everybody kind of understands. So with testosterone, you can get the rice grain that sticks into put in to your right butt cheek, men, and then you can have the injections, and you can also have like a roll-on. Well, if you have a roll-on that goes underneath your underarms or anything like that, guys, you can't have your young baby girls lay on you, and then also can have some effects to your wife. So that's something you have to think about if you ever have to get onto the testosterone. That if you have a little young baby, a little baby girl, or a wife or a pregnant wife, you definitely don't want to put that medication on the roll-on testosterone when you're in the home because it's going to have issues there. Some considerations when talking about drugs and pregnancy. What's the expected benefits? What are you looking to get out of this medication that you're potentially giving them? Is it going to cause a risk to the child or the baby? Changes in pregnant woman's body by effect of the way of the drugs process. If you're trying to give them let's say, Zofran, and I give her IM of Zofran, well, Mickey's COVID vaccine is stored at a 36 to 46 degree, up to 30. Yeah, see, so it's got to be refrigerated too. Not super, super cold, but it's got to be kept in a refrigerator. Appreciate you pointing that out. So if I'm giving this pregnant lady Zofran, her body's going to process it faster, and it's going to go through the baby. So that's something that I have to think about too, is what's my dosage on a normal person Right, Victoria. Insulin has to be kept in the fridge. Prime example. Always check the fridges of somebody's house when you go to take care of them, because sometimes they may just not tell you, and you look in there right around where the butter's kept. Everybody knows that's where they keep the medicine 90% of the time. So when I'm given like that medicine, you just need to know what's your what's your target. What are you trying to get out of that? And then the FDA regulates categories and indicate drugs that are become a problem during pregnancy. That's the reason why pregnant ladies really can't take anything unless it's was it OTC, Pepsid, or chewables to help with. And then it's like what Tylenol is all they can take. As you can tell, I haven't had a baby in quite some time. Mine's 6 now, and that's it. That's all we're having. Some special considerations, pediatrics. That's a big one. You're gonna at some point in time, guys, y'all are going to take care of a pediatric, like it or not. It's yours. You're gonna get that call. You're gonna have to go do them. So you might as well kind of get understandings of what's going on with a pediatric. The good thing is about peds, if it's ever unfortunately a trauma call, we have the Braslo tape. If you've never put your hands on a Braslo tape, it is the most amazing thing that's out there, in my personal opinion. You lay it out, you tape it on the backboard, and it tells you, it breaks it down of every single thing that you do. How much drug you give, what's the dose, breaks it down in milligrams per kilograms. I've seen some services have a pediatric ALS bag also, to where if they have to do a pediatric cardiac arrest, you still break out the Braslo tape, and the medications are colored. Like the syringe, say it's broken down into purple, red, green, and I don't remember what the other colors are. So if they fall into that, you either give them that of that syringe, because the syringe is is colored, or you use that color syringe. I've seen both of them in different services. So it is really freaking cool. It's a lot of money to have it set up that way. So some services just buy you the Braslo tape and kind of say best wishes. Um, Young infants have the reduced metabolic capacity. Children can metabolize some medications quicker than adults. So again, you want to know what are you trying to get out of it, and think about that. If you give a kid a medicine and you're like, oh, that's gonna last 30 minutes before we get to the hospital, well, it's not, because their bodies are going to process that, their livers, their stomach, all that's going to be worked out a whole lot faster. That's something that's And then we talk about the geriatric patients. Theirs is going to be a little bit slower. Some things are going to take longer to affect, or it'll affect them the same amount of time as a normally healthy adult, but it just lasts longer because their body's not going to process that. Um, you talk about geriatrics, you talk about hepatic functions and the gastroactivities, obviously slow and delay absorption of medications. We know that. I always try to say when I have a student on the truck, everything with the geriatric word slow, watch them walk, because they move slow, they talk slow. Think about what, like, their heart's gonna beat a little bit slower. Like we just said, it's gonna absorb a little bit slower. So just remember that. Like I'm talking to you guys, I am talking kind of fast. Unfortunately, it's kind of normal, but you may have to slow down your discussion when you're talking to uh, 65 and older. Is kind of like I like to put it. I don't mean to call them all geriatrics, but you got to kind of give them a category. And then when you get their medications, you're going to think that's a Walmart on wheels, because a lot of them have multiples. I always joke when you tell the little old lady from the nursing home, let's get your stuff and get ready to go. You got to have a bag just full of, like, a suitcase bag for medications, and then another little bag for their clothes. And then your report wants you to write down all the medications, and you're just like, no, man, I only got 30 minutes and I got 900 medicines. So in my younger days, I would just write TML, too many to list. So those are some of the things that I just didn't do. When we, and then you say complementary therapies may interact and modify affects each medication. So depends on what you give these geriatrics. If you, uh, the nitro, how much paste are you going to put on them? versus how much spray are you going to spray underneath their tongues. Do you really need to give them that full desired dose? I understand that's what's written in your med control, but pick up the phone call and call them. It's always good to pick up that phone and be like, hey, doc, this is what I got. This is what I'm looking for. Are you okay with that? And can I do this? So ask those questions. I say ask those hard questions because if you ask the good questions at a young time when you're on your game, the doctors start building a little trust in you and they understand you're like, hey, look, this person's not an idiot or this person is an idiot and you won't ever get to do anything on your own. So think about those things when you call med control. Uh-oh. All right, there we go. So scope of practice. You are legally, morally, and ethically responsible for each drug you administer. I'm going to say that again. You are legally, morally, and ethically responsible for each drug you administer. So let that sink in, guys. So the drug administration must be safe and therapeutic effects. Always keep a field guide for references handy. I always used to keep my ALS guide in my pocket. And I want to say they have a BLS little flip guide, and you can also put it on your smartphone. So that's not a problem. But know the medications that are on your truck. Know when you can give them, know when you're not supposed to give them. And if somebody has their medications and want to take it, know what to tell them. Don't just assume. Ask questions. If y'all are hiring onto a service and you have to go through orientation, ask them, hey, so let me ask this. I always joke and say you don't want to be that guy, but you want to be that guy. You want to be the guy that asks the questions, that you want to make sure you're clear because you're going to get that call, because that's the way that karma works in my world. I'm gonna be the one that gets for everything, but you just want to know on the front end what's coming up. You want to know if you're safe to do that, if you legally can do that, and then ultimately, when it comes down to it, you're the one that's going to sit in front of the court and read your report and answer questions on why you did that. So, again, at the top of the sentence, it says you're legally, morally, and ethically responsible for each drug you administer. As y'all can tell, I think that's pretty a big point. That's why I keep going over. Okay. Methods of drug classifications. So based on the effects of drugs, have a particular part of the body or specific condition. They're classified into three big regions. So you go with the body system, the class of the agent, and the mechanism. Blah, 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 blah. Sorry. We're going to move on. Keep going. So body's principal control. Somebody say something, or is that just me trying to talk? Maybe having interference. I don't know. So based on the effects, where am I at? Body's principle, sorry. You're going to compose of the CNS, which is the central nervous system, and the peripheral nervous system. So the peripheral nervous system is included in all nerve tissues outside the CNS. That's what's the medication you're ultimately given is going to affect. Is it going to affect either one of them? Contains the automatic nervous system. The ANS is divided into the sympathetic and the parasympathetic nervous system. So these meds that we go over, that you carry, that everybody has, everybody takes, affects these regions, affects these conditions. Not trying to say know them, but kind of have an understanding of these medications. I actually looked for a good video. There's one out there on YouTube. I couldn't embed it in the video in this presentation for some reason. I guess it's user error, about understanding more of the alpha 1 and 2 and the beta 1 and 2. It kind of, I would say Google that and try to get you some better understanding if you have questions on that, because it's a really, really good video. So here's some of the hormones released by the sympathetic system. They stimulate certain hormone receptors. The adrenal receptors cause a response to target an organ. So there's 4 types, like we just said: the alpha 1, alpha 2, and the beta 1 and beta 2. Medications will also affect these different receptors. So if you have a beta antagonist or an alpha antagonist, you want to know it's which one their ultimate goal on affecting is. They're made specifically for those reasons, and it's kind of neat when you break it down and watch and see how good they work. So you have your sympathetic. It mimics the effects of the sympathetic nerve system, and sympathetic, it inhabits The sympathetic nerve system is also known as the anti-adrenal gland or anti-adrenal. So your antagonist, it's to counteract the actions of something, and then obviously so you have your agonist, so it binds the receptors and causes a response. It's the same thing in people. You have people that antagonize you, and the ones that kind of sit there and just kind of they wait and they react. It's the same thing when you're talking about the drugs here. So which ones are they? Are they anti? Are they agonists? You just got to figure out. It should never break down that level that far to you guys, but it does help for an understanding. And I told y'all like this chapter's it's really deep for the basic level, but I was hoping to try to break it down the best that we could so we could get an understanding out of it. Like we said, beta blockers, it's a lot of them blood pressure medicines. They also affect the heart rhythm. I've got a video at home, and I know on my hard drive at home, of somebody that has a heart dysrhythmia. They're given a beta 2 blocker, and you can actually watch the change through on the video where they're having the rhythmic, the dysrhythmic, and then once the beta goes through, you can actually see the heart rhythm change. It's really cool. Once I get home, for the short time that I am at home, I will see if I can track that video down, and at some point I'll remind it and show it to you guys. So talk about the beta 2 is a bronchodilation. That it doesn't affect the heart. We do have medications, and a lot of us carry those. Like I said, I don't know what services, what states that you're in that you may go to. So revert back to your protocols and talk to your QA, QI people up there, your training officers, to go over which drugs that you have, just to kind of so you'll know if they're a beta 2 or if you have any, so you can get that information for yourself because you need to know. So we go over the parasympathetic, sympathetic. It's hang on one second. I'm trying to look at a quick notice that came up on my computer. All right. So any of these medications are the biggest thing that we need to look for. Does anybody know what, before I wrote it down there, have y'all ever heard of sludge happen before? Especially some of you fire guys should know what sludge means. Has that popped up in your history before? All right, Mary's no. All right, so sludge normally comes when it comes to hazmat. You can get some chemicals that can create this, but in the medical field too, is you want to make sure that the patient, if they do produce any of these symptoms, it's automatic. You need to go to your trauma center. That is a very bad situation. You can see some toxicities that are shown. That are shown due to the exposure of some medications. So if y'all, I would probably write this down that I'm trying to keep going circling over. It is the sludge. That is correct, Mac. Methyl ethyl bad stuff. That is, if it's pink and purple, you don't want to touch it because you're going to have issues. So on sludgeum, it's salivation, lacrimation, urination, defecation, gastroparesis, emesis, and meiosis, which is pupil constriction. It's very, very bad. All of those, and you're not just going to see, now, I mean, you're probably going to see the urination on like your drunk person or your defecation on your people just don't care. So I'm going to tell you, those are probably common, just to be honest. But all of this together is not common. There are some medications that some services carry if they have the big, I'll call them refineries in their areas, and they know that that's a potential exposure, or the potential refinery knows it. They will sometimes have that on there so they can give it to their people if it's exposed. A lot of times that medication is so close to that material to where if they have a rupture or a break in containment, they just run and forget the medicine anyway. So then they expect the EMS to have it, and you're like, what you want me to do? I can't do nothing. I can't fix that. So just remember sludgeum. It's very, very bad. It's nasty. I've seen people basically die from weeping out of their pores. They just lose all of the liquid that's inside their body. I'm not gonna say that it's blood, but I've seen exposure and from they had every symptom of sludge. So it's not much you can do. It's kind of bad. So some more effects. So antagonists to parasympathetic nerves, so so-called anticoagulants medications. Atropine is one of those. So you can use atropine for a lot of the things. I was reading some notes there. So atropine does help with that, clears a lot of that up, but we don't just carry enough of it. And when I say a lot of it, you're up to like 20 and 30 dosage of this stuff. That's unfortunately the reason why I got to take care of this patient that passed due to sludge and their exposure. I just ran out of atropine. I met with 2 trucks on the way into the hospital and got all the atropine from them. There's nothing I could do. So some analgesics medications that relieve pain and include the relaxation. Basically, it's going to suppress their systems. The opioid agonist, it's like we talked about earlier. It's just an open opioid. It creates the depression of their CNS, so you have a little bit more relaxation. It calms the patient. It just we give it when we can. A lot of times, some of your narcotics are used for those reasons that the medic carries, or you may have, if you're on a basic truck, you may have to intercept with a paramedic to come assist you. Due to that's what's needed, and that's what those medications are for. You're not really going to carry a lot of these meds, but you just want to know the difference in the way that they're broken down. Some non-opioids are they do alter the production of the protagonisms and I'm not even going to shoot for that word. The aspirin that you can give, ibuprofen, acetaminophen, those are the same things. They have some of the effects that's non-opioid. So you can go from there. All the drugs are broken down into different categories. Let's see, did I hit that one? Nope. So Narcan, we talked about that earlier. Naloxone. Has anybody in the class that given Narcan before? Is that something that you have done in your past or used? Mac's probably given, unfortunately, a lot. Like I said, I don't know where a lot of you guys are from, but I've worked for some places due to contract and or government contracts that you literally are carrying that left and right. Used it a lot on some of the public in Afghanistan because opioids they free. They grow them over there very wild. I've seen the plants. I've walked between the plants. It's kind of neat. Mac, you're lucky if you only given it twice. I remember one rotation when I was back home. I worked on the truck. I did it 6 times in a 12-hour shift. So we're starting to see those issues with the opioid overdoses. I mean, they're selling Narcan and I think it's Walgreens, CVS now. So obviously there's a very bad problem, but they don't want to fix the drug problem. They'll just put it out there so you can buy it over the counter. Some opioid antagonist can decrease pain, but it's diminished function to the respiratory system. So you're gonna deprive it. You're gonna let's see, yeah, Mac, you're gonna use it a lot. It's Coleman. I hate to hear that, Indian. It's potential exposure. Some people can have an exposure and still need the medicine given to them. So opioids are good and bad things. I'm gonna leave it like that. So you can help with a patient to sleep through a medical procedure. You can sedate them. Drugs that can create sedation, benzos and barbiturates is basically the easiest thing that you can do. A lot of those are given through your nurse anesthetist, and it's pretty neat to talk to one of those if you ever get the time and the different drugs and all the stuff that they use and push. It's a good education there. See, anticonvulsants used to treat seizures. We all know that one. It's influx of sodium to the cells, kind of slows things down, kind of fills it up, and it's decreased the cell's ability to depolarize and propagate the seizures. So some people, I don't know if you've covered this, but all the different types of seizures. that are out there. You can have some as minor as the daydreaming. It just looks like the 1,000-yard stare. Anybody can have those. It's just a small little glimpse that you just feel like, oh, I was locked in space. I'm sorry, what's up? It's just something that happens. We just call them the 1,000-yard stares. So, not I'm saying that I'm gonna give you, some medicine to keep you from daydreaming, because I'm not gonna try to sedate you from that, an anticonvulsant. But you know what I'm saying. We can go from there. We'll go over this next one, then we'll take a quick break. So some stimulants, we can excite the central nervous system. Obviously, you can see there it increases the neurotransmitter and decreases the neurotransmitter. So there's different types that we can give, uppers and downers. It's kind of what we know from the streets, unfortunately. So they work the same way. Depends on what kind of stimulant that is required for the particular procedure. So it's increase the release of dopamine and then the norepi to increase the wakefulness and awareness. So it breaks it down again. Is it an upper or is it a downer? High doses can cause increased nervousness, irritability, tremors, and headaches. So certain, uh, Chase, that now you know why I'm not telling you have seizures, but now you know what they're also related to. You just sit there and you're staring off in space. That is a form of seizure. It's not one of those that they're going to be like, oh, you have seizures. You can't do certain things, but it is a certain type of classification. I do that too. Matter of fact, I'm waiting on the helicopter to come here in the morning, and I've got about 4 more hours of work after I get off the computer with you guys. And I'm like, man, this helicopter can't get here fast enough. So today I caught myself just daydreaming of everything I had to do to get home. So the guy that's in here that does our COVID testing, he's like, bro, you having a seizure over there? I was like, no, man, I'm just stuck. And it just dawned on me. I was like, well, yeah, technically I am. I just stared off in space. Um, so the nervousness, the tremors is because of the super high dose of this medicine that they're giving you. Prime example, some stomach medicines can be used for headaches. Uh, it's crazy on how they find these different medications, on the way that they treat things. Certain CNS medications can be used to create from help with, you know, the bowel movements, and it's so crazy. We could go on for hours on talking about that, but it's nuts. Um, Real quick, I have 7 on my computer in, and if not, we're close enough. I'm going to take a 10 minutes from you guys. Any quick questions or anything before we move on? Doom, doom. All right, guys. 10 minutes. See you at 10 after. And until then. All right, let's get back to this. Can somebody hear me? All right, so Mac, what page in the book are we? I don't see any of on the screen material anywhere. I was about to ask the same question. So yeah, unfortunately, the PowerPoint is due to Jones and Bartlett. I think y'all are using what the emergency service book or something similar to that. Is that about right? Uh, man, I can't answer that question. Come on, but I know that it follows the same thing. Yeah, emergency care transport. So give me 2 seconds. I want to sit here and I want to look up something on the resource page that I can use. Let's see. Hey, so while I'm looking for this, will y'all tell me what an example of a upper is that is legal, um, and everything like that? Somebody tell me that. Amphetamine, that's a good one. Um, what else? Anybody else? Adrenaline, that's a good one. I'm thinking something simple. I'm gonna go simple.
Nicotine or caffeine.
That's honestly the two I was looking for. So yeah, Ritalin does, but you gotta have that prescription for that. That's what they say. Some people can find it elsewhere. Um, but nicotine and caffeine are the two biggest ones that's out there that everybody use. Prime example, I don't do any tobacco. I have, thank God, stopped that. But every once in a blue moon, I forget how it affects my body, and I've always loved chewing tobacco, always loved it. So I'll be like, oh man, I'm stressed. I need some chewing tobacco. I'll go for it. Well, not too long after that, I just feel lightheaded. I feel dizzy. Um, don't get the headaches, but you'll get a tremor every now and then because of the nicotine overload. So it does that for you. A lot of caffeine, some heavy energy drinks can do the same thing for you because of the caffeine power that's in there and a few other things that are in those energy drinks. So those are out there. I say free to you, but it's put in a lot of things that we do. Caffeines can cause headaches, but they can also help reduce the headaches. So I use mine. I try to drink water every day. That's my main thing, and I only have a caffeine for my meal. But sometimes when I get a really bad headache, I have to use a caffeine to kind of help me reduce those. So they are good tools. You just have to use them in moderations. All right. So let's go over depressants. So it slows the brain. Maybe it's prescribed to treat anxiety. A lot of ones you hear about, the ones below, are treated for anxiety, muscle tension, some pain. Valium will be for there. Insomnia, stress, panic attacks, and seizures. Here are some of the depressants. We know them probably by the Ativan, the Valium, the Xanax, and the Ambien. It's the ones we know for. Uh, funny story, I took an Ambien one time, couldn't sleep. I had jet lag very, very, very bad due to traveling with the government. I didn't wake up in the same facility. I was at another camp in Afghanistan because I walked there. So we don't do that no more. We'll stay away from that. So make sure it's yours. It's got your name on there. Don't try to take anybody else's medicine. That was a learning tale for myself. I tattle on myself. So don't take something that's not yours. Um, so those are some of your depressants that you'll see out there. Um, some of your psychotherapeutic drugs. So it blocks the dopamine receptors in the brain. It's used to treat some illnesses such as schizophrenia and depression. It's associated with a host of side effects. Whew, is it, man? Do these medications cause some side effects? And not only side effects, some of the personal effects will come out with some of these medicines. So they use a lot of the depression is treated with these. So they use the tricyclic antidepressants. They use MAOIs, SSRIs. A lot of your MAOIs are more common, and some of your TCAs are than your SSRIs. It depends on which one's good for your body. They will put you on some of these, and you'll go and go and go, and then you have this adverse reaction to them, and then they'll have to change you. And it's a constant battle until they find the exact one that's good for you as an individual. If you ever have to put on these, or somebody that you know. So unfortunately, that's the reason why even on a lot of medications, they may have to try you on a couple of times to get you on the right track. So just because it's easy to go see a doctor and then give them a prescription doesn't mean it's always going to work on the first time. Some of the drugs that affect the cardiovascular system is can anybody, before we go any further, so the three that's listed there, anybody give me an idea what medications will fall into those? I'm going to give y'all a second. I know y'all are going to Google it. So just Google away real quick on the chronotropic, inotropic, and dermatotropic, and tell me just give me a drug, and we'll move forward on that. Atropine, good one. What's another one? Dopamine. So some of your dermatotropic medications will also have a vagal stimulation. So think about that or what you give. It is, Mac, I'm not sure about aspirin. I'm going to have to look that up so I can tell you. Yeah. So chronotropic drugs are those that change the heart rate. How about that? So, and it says, here it'll say there are some effects of the central and peripheral cardiovascular adaptation to exercise on aspirin. So it affects the cardiac in certain ways. So yeah, I'll give you that one. That's a good one. So antiarrhythmic medications. You have your sodium channel blockers. This is what I was talking about earlier about your beta blockers. You can the potassium, the calcium blockers. These also are very hard to make sure you get the right ones. The dosages, a lot of times after you hear people come out from bypass, double bypass, triple bypass, they're started on a beta blocker, and they have to rotate their medicines first to get them out there. So your beta blocker reduces the adrenal stimulation of a beta receptor. Some of your potassium increases heart contractivity. And let's see, calcium decreases the force of contraction and automaticity, and it decreases the conduction velocity. So each one of those affects it in all different ways. I mean, you're like, wow, I thought calcium was just in the bones, and give me some of that milk, get some of that calcium out of there. So they affect us in all different ways, and there's reasons why you get put on those medications, and it helps us live longer. That's what we want. Some of your diuretics affect that, causes kidney to remove excess amounts of salt and water. Your vasodilators, smooth muscles. That's actually a big one. You mentioned figure that which ones affects your vasodilators. Sympathetics. The blocking agents diminish effects of a beta stimulation. Your antagonisms, converting enzymes, your ACEs, your ACE inhibitors. Those are you'll hear that a lot when you go into pharmacology for paramedicine, and then to your advanced, you should hear that and a lot deeper. So your ACE inhibitors, they target the renin and antigens. They will mess with the cardiac system pretty heavily. So that is something that you need to know the difference in there. So on your ACE inhibitors, sometimes it'll have your calcium channel blockers will be messed up in there, and that's what you got to be careful on. Another medication that's what I was actually telling you guys about earlier on when you do your assessment and you do your patient interview, and that's what I call it because I'm trying to get the basis of them. If they're on a calcium blocker and they're on an ACE inhibitor, they're not working good together. So that's another issue you got to affect. Um, let's see, your sympathetic blocking agencies include beta blockers and adrenic inhibitors. Diminishes effects of the beta stimulator. So again, that's way over all of our heads. That's a cardiologist going to have to work on that. And then they'll have to go between the cardiologist and their primary care physician because of the medications that they may have them on are going to react to this ones. So it's one of those you're just like, that's a lot. I mean, it is a lot when you start talking about pharmacology for basics. So your anticoagulants, your fibrolytics, and your blood components, all these you will probably never transport those unless you drive a critical care truck there, or you may do a nurse trip with these on there. It's very rare you're going to see these taken just by a ground ambulance, unless you have maybe a flight crew that can't fly due to some other reasons. So you have your antiplatelet agents and interferes with aggression of a platelet. And then your anticoagulant drugs work against the coagulation to prevent formulation of thrombi. Your fibrinogen agents dissolve a thrombus and prevent it from breaking off and entering the bloodstream. Clot Busters, Mac, maybe we stated already, but what antacids fall into this category? Which category are we talking about? Cardio. So no, you're getting more of the acid from the stomach. It's going to affect you in the GI tract mainly. Does that give you your answer you're looking for, Mac? Let's see, like I was doing over the fibrinolytics, dissolve a thrombus. So that's going to do your clot busters, your anticoagulants. They work against the coagulation to prevent it from forming a thrombi. May be prescribed as a long-term basis. A lot of those may sit in a facility, cardiac rehab. It's particularly when a patient has sustained a traumatic injury and can prevent life-saving coagulation needed. So if they're unable to coagulate, their iron is super low, or they just can't get that clot to go, they may give them some of these medications to try to help that. And that has to be monitored. That's an ICU drug, PICU, PACU. That's in all those for pediatrics. You have all your different ICUs, cardiac ICU that you may see these hanging down to. It's I've seen them I've actually seen them in the PACU for the kids, or I know for a fact for the PACU that it was in such minor dosages that it had to be measured out and given by a pharmacist each individual time because of the amount that could not be given because it's so low. It's in the micrograms, and that's something that we're not used to doing. Trying to see where I'm at on my slides. I clicked on the wrong one on my screen. All right, so some of the drugs that affect the respiratory system. So I don't know if some of you knew, but technically oxygen is a drug. Gotcha. I always hear patients being given certain drugs during cardiac arrest. I was wondering if they're ready for. I see where you're going. But you'll have your calcium chloride, that you can. Mac, I'll tell you what, I'll take you offline and I'll send you a message once this is over and go a little deep with that. So on your oxygen, you have to have basically an order. So your ambulance service, sometimes your fire services will fall underneath your ambulance service to get supplies, and then that's how your oxygen's ordered. You have to have a doctor sign off on that. to get you your medicines. So, and then the use of OTC decongestant medication is common during the cold and influenzas. That can affect your respiratory system. Many respiratory emergency treatments use sympathetic medications. Then you have patients that take antihistamines. You know what that's going to do. You can affect respiratory drive. People have been known to overdose on a decongestant, uh, dexamethasone and diphenhydramine, which is an antihistamine. They take too much; it dries them out. It's taking all the water out of them. Your decongestant is pulling the mucus out of your body. And Benadryl, yeah, people OD on Benadryl. They think that they're just sleepy, and sometimes they just don't wake up from the overuse of it. Trying to slide down on this. So many respiratory emergencies, the treatments use sympathetic medications. The stimulation of a beta-2 receptor is most beneficial to a patient with respiratory emergency. Xanthanines is the second line of treatment. It relieves the airway constriction by relaxing smooth muscles, and it stimulates the central nervous system. Caffeine is a well-known xanthine and a CNS stimulant. And so if it's like right now when we have the sinus infections, that you're gonna get tested for COVID if you go in and you have the flu anyway. That's a common practice out here. If somebody comes in stuffy nose, sinus drainage, anything like that, they're automatically flu swabbed. We do onboard COVID testing. They're tested basically 3 nasal swabs, and within minutes we'll know if they have COVID because we are actually out here testing for the protein and not just the signs of it. So if you come back positive on either one of the COVID and the flu, you're automatically flown in as a PUI, which is a person under investigation, and then you're monitored for 14 days for any other symptoms. So if you go to see your doctor right now for the flu or any symptoms like that, be prepared. You're going to get nose raped. That's just the standard practice these days because COVID out trumps the flu. So you have different drugs that affect the pancreas. Some acts on the pancreas directly. It doesn't get filtered out. It goes straight there. Others alter the way the insulin is used by the body. It may decrease it enough. Others alter I just said that. And then insulin sensitivity is increased by oral hypoglycemic agents, and insulin sensitivity is increased by hypoglycemic agents, thiazide and backwardines. I was just looking to see if I could give you any extra information there. So just remember, on all these drugs, they're going to affect each different system of the body in different forms. That's a big thing for us to make sure. Just to ask questions, get the learning, figure out who, what, when, where, and why. Why is this important? Why are they taking that? Ask a lot of questions. So immunosuppressants. So medications are often prescribed by a patient who's undergone an organ transplant, have an autoimmune disease. A lot of these you won't see outside the home or facility in several months because they're susceptible to getting infections very easy because their immune system is already compromised. If they've gone through the organ transplant, they don't want them out in the general public for quite a while because of that reason. Autoimmune disease. My mother had one, and she would quickly get things. She would get an infection a lot faster than others. Certain things would bother her a whole lot worse. She'd break out in a rash just because it was common then. So then it's intended to inhibit the bodies and attacks to the ability to attack the foreign organ from an organ transplant. That's the reason why you'll have where just because they got a kidney transplant doesn't mean the body's going to take it. The body thinks that it's a disease. They're going to attack it. They're going to create things, your white blood cell count, and they'll just basically shut that kidney out. And so it's very particular on how it's there. They keep them monitored very well. So that if that is something the case that the body fights that particular organ, that they can try to either do a CNS depressant and try to let the body work slowly instead of trying to fight it off. So vitamins and minerals, those are very important. It allows normal metabolism and growth and development of a cellular function. You can take the supplements. We all take different types over the, some people take D3, what is that, mag sulfate, all these different OTC vitamins that are out there. You take whatever you think that is beneficial to you and you've talked to your physician about. You will see that when you're doing a patient assessment on somebody. They may list 500 supplements and maybe 1 or 2 regular medications. And they tell you that if it wasn't for these, that I wouldn't be healthy as I am right now. So that's something that you're going to have to ask. A preventive measure in some of these supplements, I take D3 on the regular. I've been taking that since I was in Afghanistan. It's helped me prevent some of the sickness. I would tell you it did not help me from preventing the COVID. I've had it twice. It was really, really, really rough the second time. Knocking on wood that I've been blessed. I'm still up, kicking and moving. So some people believe in them, some people don't. That's up to you guys on what you decide to do. So we'll talk about fluids, electrolytes. So there's 3 different kinds. I'm sorry. You have your isotonic, hypertonic, and hypotonic. And that's the same thing that you carry on the truck, squad, ambulance, fire truck, whatever you guys want to do. And then you have your, let's see, we talk about the different types. You have your LR, you have your normal saline. Those are your most commons that you're going to see out there. You may have, was a D25 in a bag, but D50's been pushed. So you'll have your different type of solutions. You just need to know which ones you have on your trucks. What's more beneficial to the patient? Do you want LR that is a more of a filler, or do you just want the regular old IV bag that's hanging? So it depends on which one your medic needs. You may just want to pull them out prior so you'll have an understanding of that part. The breaking down of different medication forms. This was kind of important. I put this in here for this particular reason, so you can kind of understand why the medications are made this way and how they break down, which we should know. It's most adult medication all comes in these forms, and all of these forms. Some kids will only come in the liquid form. For the ones that do have young kids, you all know sometimes you just want to hold them down, squirt the medicine in their mouth, and they'll be okay. And then after the first time they take it, they love it because it's flavored. So they have capsules, the gelatin shell. If it's powdered, you can sometimes, when I say the shell can be pulled apart, it's because it's a powder. You can break it apart, pull it apart that way. Liquid, you should be able to pull poke a hole in it or separate it by, some of them are heated to where they hold the liquid on the inside so they can dissolve that way. The tablets, they are compressed under very high pressure. We have a compounding pharmacy in our area, and I had a friend of mine that owns the place, and she showed me how they make their tablets, which is really cool. They have a compression. I'm not going to say it's a ton of pressure, but it's a lot of pounds of weight that compresses these tablets into there. So the medication is mixed with other materials to do the compound to create Tylenol. So it's not just like you saw when we broke down the medication, everything that's added into it. You'll have your time released. You may have some that's a rapid release that are made into tablets. You'll have like your sublingual nitro, which is some of the patients will carry them in their pocket. That's the same thing. So the sublingual nitros are also in the little tinted bottles. Don't ever, 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 ever put those in your hand. You will get some of the powder and it's quickly absorbed in your hand. If your partner ever pulls out the nitro spray, hold your breath, turn the other way because you're going to smell it if you've never done it, and you'll create a really bad headache. And a lot of them dissolve slowly in the digestive system because that's the way it's programmed. It's the way that it's made to do. and through time, that's the way that they dissolve. Solution and suspensions. This one's kind of breaks it down into it's a liquid in the solution part. It's made up from one or more substances, so they may mix a flavor in there. They may have some water based into it. Some of the medicines I've seen for kids that helps with anxiety are I want to say an oil base, but I don't think that's exactly correct. But it's got several different mixtures in there. And it cannot be separated by filtering or allowing to stand. Some of the medications you'll see at home, you're like, oh, wow, that's separated because you've sat there for so long and the medications itself has split. It's just like oil and water. You'll see the separation in there. With the solution, you can give it about any route, oral or injection, depends on where it's at. It can be drawn up. Sometimes with this solution, you can also give it rectally. Depends on what type of medication you're trying to give. A suspension is a solids or ground into fine particles. You break it down in a liquid. You can give this by gluconate. It's the same way. You have to dissolve it in a normal saline, and then you draw it back up into your needle. Right there, the solids will not dissolve in this liquid. That's why it's in a powder form. They'll separate over time if you allow them to sit still. If you allow them to sit mixed, that's the reason why that they'll dissolve over time. Now, if you mix these together and then you try to say, oh, I want to wait and watch it, you're going to be sitting there quite a while. This is a couple of hour intervention that you're going to see these medications take. Once you mix it, you got to shake it very well. The gluconate for sure. You inject the normal saline in there or the distilled water, and then you shake it up really good and you draw it back out. I'm sorry, that reminded me of like the hokey pokey all of a sudden. I apologize, kind of giggled there. On this particular medicine, you gotta, if it's a suspension, you gotta give it orally. Some meter dose, we're gonna talk more about your inhalant, your albuterol, your breathing treatment, your asthma medication. So when I say meter dose, it's every time you push the button, a certain amount comes out. That's pre-programmed, pre-done by the way that the manufacturer has had it done. It's absorbed into the lungs. You take that deep breath, and it attacks to the particles it needs to in the lung. Must be shaken. That's why you see all your respiratory patients that carry their own inhalers, that they turn around and shake them prior to giving because they want to mix it up pretty well. But it's just because they do sit on their side for a while. Some topical medications we're going to talk about. Those are just applied to the surface of the skin. You can put it on, like I told you earlier. I call it's a cream really for the testosterone. It comes in like a homemade underarm, like a homemade deodorant, but it's testosterone. It's a certain amount in the entire vial. So if you give yourself 3 rubs instead of 2 rubs, it's ultimately the same amount because it's not gonna. The whole vial may have 100 ml of testosterone in it, but it's made with something to create it as a topical lotion. Your ointments are the same way. What is the one medication that y'all can think off the top of your head that is used in a topical medication? Can anybody guess? All right, sorry guys. So Chase, yeah, that's an NSAID that you're talking about right there, and their hydrocortisone. You can use that as a cream. We use that a lot offshore as the hydrocortisone creams in little packets. You can use we carry it out here also. You use it as a nitro paste. It's a meter paste. You put it out in a certain length, the whole pack, and it's absorbed through the skin. So it's a topical cream that both of y'all are right on point on all those. Let's see. Transdermal medication is basically applied the same exact way. It's designed to be absorbed through the skin, same way as your topical medications. And I already asked the question. So it's usually intended for the semestic or the whole. Whoop, sorry guys, wrong one. I apologize. For the whole body to affect it, nitro paste is what we're looking for. So you can have your patches, you can have your nitro patches, you can have your nicotine patches. It's basically the same thing. I will tell you over time, it is in the best interest. If you're working on these patients and they happen to go into cardiac arrest, to remove those patches, look for the transdermal patches anywhere on them. Sometimes you will have some of your excess drug users. Actually, I've seen people chewing on these to try to get every bit of that narcotic out of them. I've seen them put it between their cheek and gum. So make sure you check your patient. You want to make sure that it's just they don't have any of the clear ones on their body. I want to say like the nicotine patches or the transdermals are clear. I think they stick them to their arms, either arm. I'm not really sure. I've seen the nicotine gum. So it's one of those you just want to make sure you check your patient before you have to start working them in cardiac arrest, or if you shock them. Not saying they're just going to automatic, you're going to get a overdose of medication if you shock them, but just as an FYI, remove that medication, because if you give them the nitro, they have a nitro patch on, and you're giving them, the sublingual nitro, and you're double dosing these patients when they really didn't need it, and you're wondering, well, why is their blood pressure bottomed out now? Because you're spiking the dosages because you didn't check for that patch. Some gels, semi-liquid substance. It's administered orally. It's generally the consistence of a paste or cream, and they're most of the time clear. I've seen them kind of like a clearishly white. That's the I think it was supposed to be clear when this guy's had it, but he had it for so long. Gases, majority of it's mixed with oxygen. Like you have I call it your funny gas. You go to the dentist. My daughter still loves it. She said, "Dad, I need some of that funny gas at home." Nope, no, baby, you don't. You don't need that. It's just a mixture of oxygen, so you have all your different types of gas. So some of your different routes of medication. So this one gets we'll go pretty deep in this one. So you can either go external, orally, rectally. We know more external drugs are administered along with portion of the gastrointestinal tract. We know that. So here's some of your, it could have been, Mac. I'll give you that one. Administered through any route other than the gastro tract. So here's how you're normally going to see them in the EMS side, the hospital side. So you'll have IV, subcutaneous, IM, which is intramuscular. You have your oral, your interosseous, and that's your IO, like we were talking about the IO drill. Sublingual or subcutaneous, transcutaneous or transdermal, intranasal, inhalation, or per rectum, and those are your different abbreviations for those particular ones. When we talk about the sub-Q, which is subcutaneous, it's just a little s and a little q. I apologize for not writing that one down. And all the rest of them are most of the time all capitalized. If you're on inhalation, it's not a abbreviation on that one. You just don't put an I. Somebody thinks that may be saying I what. So a lot of the drugs we give are all IV, IM, or sub-Q. So that's one of the ones that you say right there. So intranasally, what did we talk about earlier that's given through IN? Anybody want to guess real quick? Narcan. It's the #1 drug out there that we give. Oxygen. You got me, Victoria. That's a good one. All right, so break it down on why these medicines are given this way. So through IV, it's injected directly into the vein. It's just like starting an IV out in the field, having blood drawn, straight out the vein. Enters the bloodstream immediately. It's the fastest way to deliver a medication. Back in the day, I will tell you, in my time when I first got into paramedic, if you couldn't start an IV in the field, it was very, at the time we didn't do IOs unless you were on a pediatric, and that was through manually basically pushing IO in. You could actually dump the epi and atropine down the tube. Just squirt your regular vial down the tube, and during compressions and bagging, they said that was done one of the best ways. It kind of got quickly shut out because that was obviously not the best ways. Not all medications can be given IV. Like, matter of fact, aspirin and oxygen, just not going that way. Oxygen can kill them if you put it through your vein. That's the reason why you get all the bubbles out through your IV. Orally, that's a PO. You take it by mouth. So it enters the bloodstream through an oral mucosa or membrane because it breaks down over time. So it's generally within the system within minutes, depends on what type of pill. That's the reason why I added about the section about the pills, so you would understand, is it a gel, is it a capsule, is it a tablet? So you all understand how it's going to break into the system faster. Like a nitro tablet, that's put underneath the tongue and it's absorbed through the mucous membranes. So that's kind of important. So you know which way you're going to give it and how fast it's going to get there. Sublingual, it's under the tongue. So you give it orally for the nitro, but it's put underneath the tongue for nitro tablet. And it's in the system within minutes. I want to say, if I remember correctly, a nitro tablet's fully absorbed in under 2 minutes. It'll go through the bloodstream through the mucous membranes, like I said, on the oral part. IM, we've all had our IM shots. Those are the ones, the penicillin, that you realize when you sit down 3 days later that it still hurts. It's injected to the muscle. Is there a nasal pill sublingual also? For which medication? Sorry, you can take Zofran that way. You can put it underneath your tongue and let it dissolve. Phenergan's more of a harder capsule, and then Phenergan works better to be absorbed through the digestive tract. Let's see. So if you give an IM medication, it's straight into the blood vessels. It's absorbed through the muscle real quick. Most time you'll go into the buttocks. Some medications can be released from the muscles. That's where you're always going to give your IM. That's why it's intermuscular. Not all medications can be given IM. Some of it can cause tissue damage. And when I say it's uneven, unreliable absorption, because you can't give it. You need to give it over time. It's going to absorb different because of the way you may give it in. Let's say if you're a muscular person, it's going to absorb different than like myself, that's fluffy or lovable. I like to say instead of fat. That's my term. So it's going to take time. It's going to absorb completely different, and depending on the person that you give it to. So depends on what medication and which route and how fast you need it. You may not be able to give it IM. So IO, you can have an IO drill, which is the big thing that you see out there now. It's drilled straight into the bone. You're giving it through the bloodstream. Requires a drill. It used to not. You used to use a little blue. You would shake back and forth on the pediatric's leg, and that's how you would get it in. It is very painful. Guys, I don't know if y'all, depends on where y'all are or where you're from. Several years ago, we had a very, very bad accident in Jackson, Mississippi, where one of our paramedics was hit by a drunk driver. I don't know if you want to say pleasure or wrong place, wrong time. I actually took care of her, a really good friend of mine. I transported her from that scene to the hospital, stayed by her side for a couple of days because she was a good friend of mine. And end of last year, unfortunately, she passed away. She ended up losing her eye, one of her legs. I IO'd her, and I did 2 14-gauge needles. So she was very traumatic. I can tell you, even once she came out, she remembers the painfulness of the IO. So it wasn't like even though she was responsive, but she was in shock, she still remembered how painful that was. So understand if you have to give an IO that you can use some medications to numb it as soon as you give it. So just remind your medic to, be smart, be nice about it. They can still feel it, I promise you. Subcutaneous is injected beneath the skin, absorbed through the skin and muscles. It's absorbed very slowly because the amount of medicine that you can give versus an IM is very different. The effects of the medication last longer, so if the doctor wants it to absorb over a couple of hours, you're probably going to go sub-Q. And example is like an insulin shot. So you may give it in the stomach where it's absorbed over time and it's not a direct shot that's going to be absorbed directly as an IO. Transcutaneous, like we went over with the patches, it enters the skin, it's produced a slow, long-lasting effect. Some of these patches can last up to 3 days. Like we looked at the nitro nicotine patches. I don't know much about the nicotine patches on how long they last. Anybody have an idea on the nicotine patches? I know nitro patches are 12 hours. And if you give them on the nitro paste, the skin has to be bare. You can't cover the skin because it can potentially rub off the nitro patches. I mean, the nitro cream. Inhalation, you give albuterol. You want to aerosol it. Some fine powders can. Sprays, nitro, the nitro bottle where you give it through the orally. Or they get your tongue to go to the top of the mouth, stick it underneath the tongue and spray. It's absorbed sub-Q and directly into the lungs. Some medications work in the lungs, and that's where it affects, and that's your point of trying to get it there. It minimizes the effect of other body tissues because it's a direct inhalation. Nicotine is a 16 to 24 hours. Oh, okay. Does that on the nicotine? Is that just depends on like what milligrams or something like that, or is that just I don't know. I'm just asking questions just so I can learn. Let me ask Google. You keep on doing that. I appreciate that. And then the rectum route delivered by the rectum is often used in children. It's easy administration. It's more reliable. I have been giving orders to give a couple of medications rectally. That was by a med control. I had one guy that was very combative, but he was supine on the floor, face down, but he's very, very, very combative. And then the doc was like, "Oh, you can give it to rectally." I'm sorry. What'd you just say? You want me to give what rectally and how? You want me to do this? So pulled my brain up. I ended up cutting a ET tube, put it on the end of my syringe, and with some KY, me and about 6 other guys got this to work. Great. But I called med control. I knew that I was unable to, go IM or get it down real quick because I didn't want to get hit by a needle, and that was his next option. That's happened twice in my career, and I'm okay with not doing that again. So we have the study of the drug absorption, the drug distribution, the biotransform, and the drug elimination. So we have all these pharmacokinetics. Let's see. So pharmacokinetics, once administered drug goes through 4 states: absorption, distribution, metabolism, and excretion. Studies of metabolism of actions of drugs. So the medication dose, route of administration, and clinical status of a patient will largely determine the duration of effectiveness of a medication. Onset and peak of a medication generally related to the absorption and distribution. A minimum dose or concentration of a medication must be present at certain sites of the body for clinical effects to occur. Drug absorption depends on the nature of the absorption surface, blood flow to the site administration, the solubility of the drug, and the pH is a big one. You got to know that, well, you don't, but the pH has got to be known before they're able to do that. So all these things are concerned when we're talking about pharmacokinetics. So they can also affect, depends on how they are in the study of the 4, they can depends on the organ excretion, how well are the kidneys working? What about the intestines or the lungs, so they can breathe this off and to work it out? The saliva is a very important. Are they being dried out? How much spit are they performing? Is it absorbed in the mammary glands? Is it going to affect the mother doing breastfeeding to the child? You need to know these things, and the doctors are asking lots of questions. And if you you're transporting somebody home, and they ask you questions, you're going to be like they said a while ago, let me ask Google on that one. So it goes deep. That's the reason why I just was kind of dabbing off into this a little bit, so you would kind of get it. And I know this draws some confusion on there, but it's a little bit will help you go a long way. Pharmacodynamics is a way in which the medication process responds we intended it to work on the human. Also include factors that may alter the intended response, and any side effects or unexpected effects. Includes factors that may alter the intended response. All right, I was making sure I got my notes at the bottom. Some medication mechanisms of actions. A drug may reach appropriate concentrations at the site of the action. The magnitude of the response depends on the dose. Medications may bind to receptor sites. They may change in the physical properties of the cell, so they may bond differently. They may attach it. The cells may react from there. The chemically combined with other chemicals. So if you're taking an OTC versus a prescription, like we said a while ago, either they can fight each other, they can work together and create adverse reactions to it. And then alter an abnormal metabolic pathway. So once a medication is bound to the receptor site, it'll initiate chemical change that produce expected effects. And that's what we want it to do. If the other medications that are in there and it creates this adverse effect, maybe it's because that OTC didn't tell us about, or the doctor didn't know about, that you started taking after this medication. So drug response and relations correlates to the amount of medication. So if the desired effect of a doctor is trying to get this person to stop having a seizure every 10 minutes, and they're only given 1 milligram per kilogram, so their desired dosages and the desired outcome is not high enough, over time they will increase that. Once they get it, let's say 30 milligrams is where they want it to be at, so it's 30 milligrams per kilogram. So now you think if they're 100 kilos times 30 milligrams, so that's what their desired dosage is, and they may have to work to that. And then they need to know how long is this going to react to the body, and then how fast is the body going to burn it. Because once this person is seasoned, they're eating up all the energy that they have stored, so they're going to be really sleepy. So is the medication going to stop them from seizing? And how long is the body going to burn it once they're resting and the seizures have stopped? So that's something they need to keep in mind. So the therapeutic index, the ratio of a drug's lethal dose, is 50% of the population to its effective dose for 50% of the population. For all you fire guys, that's the same thing as in your hazmat materials. What is it? The life. There's an abbreviation. I just went blank. So you need to know what is the lethal dose is. So if you, let's say, one drop of this chemical can kill 5,000 people, that's its lethal dose range. So that's, some of you fire guys, you take your hazmat classes, you'll see this. You'll kind of see some of the same questions. We talked about this, the interactions between herbal and OTCs. Thank you, IDLH, Mac. You heard me fighting for that in my brain. It was coming, but it just wasn't working. So another prescription, if let's say your primary care physician gives one that your cardiologist doesn't know, or vice versa, they're going to fight against each other. So if you start taking this herbal medication from whomever you go visit on your own business versus your OTC meds, some narcotics will affect. Good friend of mine, unfortunately, recently had a pretty severe heart attack, and she was a very avid weed smoker, and ended up coming that the doctor was okay with her smoking weed, and it would actually, he encouraged it, but the quantity of it she had to downplay. So she was trying to keep her anxiety in check with that, and she functioned very, very well with it. It's just the quantity. The doctor was like, hey, we need to reduce this because some of the other medication I've got you on. She did was reduce from your nicotine and cigarettes. You may have to knock that down depending on the medication and that you're on now, because of it may be a suppressant. Something in the diet you're going to have to change. Let's say a diabetic may change their medication or just change the food that they eat to a healthier one, or cut out something like salts or anything like that. Um, and what's the patient exposed to? Daily ins, daily outs of what they, go to the store and they are exposed to. I mean, I remember in my past, we'll discuss where all I've done lately in the long time. I remember driving down the road and one of my many trips and our rad detectors go off. We'll come to find out that the person beside us, after was stopped and interviewed and all that, that the person was actually going off because they had just come from a radiation treatment. So that's how sensitive some of these radiation detectors are. It's kind of neat, kind of cool. Got to learn a little bit, and it's educational. Let's see. All right. Sorry, guys. It's been over an hour. Let's take 10 minutes, and we'll be back, let's say 11 after. It's 8:01 on my clock. We'll say 8:11. We'll see y'all back in just a few minutes. All right. 10 minutes. All right, folks, we'll get back to that. Sorry, I'm giggling. I watched a video on our time off, and now I can't get it out of my head. I'm laughing so much. All right, so we'll go over some interactions. I changed slides on my other computer, so I had to go back. All right, some interactions between medications occur whenever the drug is modified. We talked about that, went into some depth on that one, so let me get back here. So some predictable responses is what we want to come out of the medication. It's what we expect. We can have some adverse conditions inadvertently introduced in a patient by the treatment. You may have reactions. You can have adverse reactions. You can have some allergic reactions, like we write there, the unpredictable responses, allergies, some serum sickness, drug dependency, drug interaction. You have some of the ones like methadone. Unfortunately, some people will get addicted to as they're trying to be taken off another drug. So you have all these, or it talks about the addictive potential. So you have to think about all that. That may be where you're taking care of a past opioid user, and they're addicted to the other medications, or it's just led them on a different path that they may have unfortunately gotten sucked into it because of the medication prescribed by a doctor. Some of the things that they look at is the tolerance of the medication, the drug dependence, the habitualness of it. That's the reason why your uh, narcotics are very well maintained, supposedly. Some doctors are monitored on how much they write per year. Some doctors in some areas write a whole bunch. Alabama, unfortunately, is known for the most narcotics to be written in America. Don't know why Alabama, but they have some docs that freely write that, like giving out Altoids or something. So you have some reducing medications. So some things that you want to make sure. Reducing medication errors. The pictures I saw on the next one talking about reducing medication. So reducing medication errors, even when you're giving it out in the field, right patient, right med, the right dose, the right route, right time, the right documentation, and the reporting that is done. Cardiac arrest medications, you document it correctly is a really, really big one. You do the right assessment. The patient has the right to refuse, route to evaluation, and the right patient education. I strongly believe in patient education. Uh, Teaching somebody the correct ways to do something is going to benefit you in the long run when you have that bedside manner that is very good to a patient just because they understand what they did wrong because they didn't know is okay. If they knew what they were doing and they knew that it was wrong and still did it, that is not. Education in our benefit, that's the time that we unfortunately see people in their bad times. We don't, like I said, we don't ever get invited to the birthday parties or the family reunions. We get there when somebody's coded or a traumatic event. So we don't have that, most of the time we don't have the ability to do these educations. So take the right time to educate these people if there's a potential chance, and it'll help you out in the long run. So here's a really good one. Use a current reliable medication reference resource. Have a partner confirm the volume in a syringe. Some agencies in the South, Louisiana, I'll leave that up to y'all can guess who kind of the biggest one is. They have a policy that if you're given a medication, you have to read it out to your partner. This is this medication at this dose at this that is read and is double checked. Hey, I want you to check, make sure this medication is done, and you repeat it loud, and you're like, that doesn't sound right. Is this what you're trying to go for? As you can see in this picture, the patient was given the wrong medication, had a very bad reaction, and that is her tongue. That's how you approach her. That's what she's been seen. You can't understand her. You try your best not to stare, but you're just kind of like, what is that in your mouth? So that's a point. Evaluate for any hypersensitivities before giving the medication to make sure that you're not giving something that they already know that they have a reaction to. Use your safe medical practices. It's been developed for a list of medications, abbreviations. Don't use the ones that you think sound right because they're not right. When you go to court and you have to read your report and you don't remember what that abbreviation is because you made it up on the fly, it's not going to work. So make sure you know if you're using like chief complaint, is it a big C, or is it little c, little c? You need to know those words, those abbreviations, uh, versus you're saying the left arm and right arm without having to write right. Is it big R, little r? You need to do it the right way. If you have trouble when you start writing your reports, get those little books that help you. A lot of them will be found in the like your your pocket guides will have some of those abbreviations in the back. That is the medically recognized abbreviations. And ask your partner, hey, is there a way that I can read your report so I can understand how to start writing my own reports when it comes down to it? Because each medic, we all write them majority in like in the chart way or the hour way. We all write them in our own ways, but I have certain things that goes in all of my charts versus some people that be like, why don't you put that in there? Well, here's why I do it. It's a consistency thing. And I want to make sure that I do it every single time so my reports look the same. And that when I write my report, I'm not missing something. That's the big thing. It's a way that I keep up with how I document, and that's the biggest part that I get out of it. Specific medications and medications only. If you have, when it says a licensed physician gives you a direct order, that is a online medical order, or you can have protocol. Make sure you know your protocols before you get out there. And then right there it says medical protocols administer that medication. If you don't know, don't give it. It's okay to pick up the phone and call and ask. And a lot of the times everybody's like, oh, I'm just going to ask another friend of mine. They may not be right. So call an online physician, whoever your physician is with your agency, and call and ask. It's okay again. And then when you see that physician, be like, hey, can I talk to you? And let me explain why. And just don't do nothing that's going to cause you morally and ethically questions and you potentially to lose your license or your jail time because you created that issue. Um, so that's really it for this evening. I'm going to finish going over some of the homework. We've already done activated charcoal. I want y'all to hit some more. We're going to go over that. I'm going to unmute your speakers from everybody, and I would like to hear from everybody so I can see who's on. And we're going to hit the other medications. We're going to talk. I'm going to leave it right there, and we'll go to the next one. So we're going to go over oral glucose. Can somebody tell me what some indications are for oral glucose?
A diabetic.
Correct.
Sugar is low.
Sugar is low. You can do oral glucose. You can have those little, I call them the diabetic, like the little Werther's originals. Those are,
Participants, right?
so I'm not really sure what those ones particularly are called, but they do have those for diabetics. So you can try to potentially do those too. Trying to send a message on. I don't know why it's not working. But Chase, I got your message. So what are some of the actions of this medication for oral glucose?
I'm sorry, I could barely hear you. Can you repeat that?
Yeah, it's whomever. Somebody's got a lot of background noise. It's kind of hard to hear. But I'm looking for some actions, what the medication, when you give oral glucose, what does it do to the body?
It counteracts the effects of hypoglycemia.
And it increases the blood sugar. You get that for low blood sugar. So that's kind of what you're saying. It interacts with the, right there. It counteracts the effects of hypoglycemia. Is there any adverse effects of this medication? Anybody?
No, there's no adverse reactions, I don't believe.
No, not for oral glucose. That is correct. Some if I'm gonna give this, why?
Tastes,
Go ahead.
tastes nasty.
I didn't catch that one. What were you saying? All right. So if I want to give this medication and I'm trying to, is there anything? Oh yeah. Sorry. There you go, Mac. It tastes gross. Some of the oral glucose does. Um, so there's precautions. I don't want to give this medicine, any oral glucose to somebody that is what?
It doesn't have a gag reflex.
Yeah. That's because it is thick. It's very thick. Mac pointed out it tastes gross. So that's another thing. If they do have that gag reflex, get ready because you're gonna hear the. I there's a lot of things.
Another contraindication would be if they're unconscious.
That is right. If they're unresponsive, unconscious, you just don't want to squirt some in the corner of their gum and let it be absorbed through their cheeks. We used to do that and turn them on their sides in their recumbent position, the rescue position, recovery position, whichever you're used to calling it. But we don't do that anymore. Somebody tell me what the dosage is.
Half a tube.
So it's
10 to 15 grams.
there you go. You read the same page I did. So it's 10 to 15 grams of the paste, and then if they're awake, is the only time you give it, but you put the gum in the cheek. You don't want them just to automatically swallow it. You want them to let it absorb through there. Like Mac was pointing out, it does have that nasty taste. So just try to tell them, hey, if possible, please don't swallow while this is in your mouth. Let it absorb, and then you can swallow. And if you have anything with them, if they have a bottle of water, let them drink that. The same thing for the pediatrics. You may have to give it through a little bit at a time. Obviously, their mouths are smaller sizes, so you'll have to give it that way. Let me click on my other one. So, when you give this, is there anything that you specifically want to document when you're going on to this, given the oral glucose?
Their responsiveness.
Yeah, that's in your patient assessment. You assess their ABCs. Are they there? Their AVPU. Are they alert? Are they responsive? Or what? If they're alert, you can give it. If they're unresponsive, can we give or no?
No.
All right. So here on some of the things that when you're trying to give this, it's Victoria, right? If you're able, some states, again, I don't know where y'all are all at, but if you're able to do a finger stick, you want to know what their CBG is before you automatically start giving oral glucose. Mary says their reaction to the medication. So you want to chart positives, negatives. If the patient was able to tolerate this medication, we kept on, started at such and such time, we ended at what time. Like it says, record name, dose, route, and time of administration. Um, Mary pointed out that's a good one to add in there to your own form assessment or your ongoing assessment is what the reaction was. Did the patient status increase? Make sense? I figure out what I'm putting there. All right, so here comes the big drug. Good and also help with airway and the respiratory. So oxygens, we can give it to every single patient that we come in contact with, right?
No. No.
Robin, I think that was you. If I saw correctly, I heard sound like a robot. Go back over what you were saying.
Only when it goes only you can't give it to everybody, but you can give it if their O2 stats are low.
Correct. You can ultimately give it to everybody. You can dosage it correctly. Like you said, if their O2 sats are low, adjust it accordingly. Make sure you don't have nasal flares that are flapping through the roof because you try to get them on 15 liters, but you've got them on a nasal cannula. Know the correct dosages for what piece of equipment you're using for the patient. Um, Here's some of the actions. I'm sure you guys Googled the same thing. Where it says, well, y'all see where it says adverse reaction effects. So high concentrations may reduce respiratory drive in COPD patients. We talked about this the other night. Is this something we're going to see instantly, or is it we're going to see it over time if we give COPD patients high flow O2?
Instantly, maybe?
Max asking, can you over oxygenate a patient though? Correct. All right, so I'm gonna top on that, and then I'll
Yes.
come back in a second. So, Mac, yes, you can over oxygenate a patient over time, but in the field, we're not gonna see the effects of over oxygenating a COPD patient unless we're on a 6, 8, 10 hour trip with this patient and we're taking them to another facility or anywhere else. That's going to be the time that you're going to potentially see that. But knowing that in the case that they're going to be a COPD patient, you're not going to keep them on 12 to 15 liters a minute, but non-rebreather over 6 hours. It's going to be a nasal cannula, maybe 2 liters at the max. Are you saying 10's the highest for a COPD patient, or what were you saying? All right. So somebody tell me what some precautions are to oxygen. Um, is there anything we specifically want to do when we're looking about giving this medication?
You never want to withhold oxygen from any
Correct.
patient that needs it.
If they need it, give it to them. I mean, ultimately, it's free when you think about it. It's just compressed into a bottle. So always give it to them if you think they need it. Go with your gut feeling. Don't ever hold it back from them. We'll skip to that one. So yeah, you can give it with COPD patients, but like we just said, just monitor your patient. Okay, I'm sorry, Mary. Um, Simple or partial rebreather face mask must supply a minimum of 6 liters, and that's because of the O2 reserve. If you want to keep that the bag filled, you got to have it in there. A non-rebreather is minimum of 12. So, and then there's no contraindications with this medicines. So if we give it, you don't have to worry about, oh, what's this going to cause? Is there are they going to have a reaction to it? Because we breathe it on a day-to-day basis. Remember, uh, we breathe how much percent of the 21% that's out there? Does anybody remember? 16, Victoria, 16. You're close. Look at there. Go to Daryl. Good job. All right, so here's our dosages. Mary, is this what you were referring to kind of when you were talking about your 10? May have been a certain device you were talking about. Any patient that's being transported should be put on O2 at 2 over time. Yeah, I agree with you on that one. It depends if you're doing like a hospital to home or a long transfer. You know, I agree with that because you're also going to run out of oxygen for a while too. So there's your dosages most of the time for adults and pediatrics. They're about the same, but the reason why they're the same is because of the tool we're giving the oxygen through. Nasal cannula or the non-rebreather. So that's the reason why it's both of them are listed the same because there's not really a whole lot. I like this chart. That's the reason why I added it in here. Just to kind of gives you a basis of what device and at what liters you can use through it. And actually, in one of my clipboards that I carry when I'm working on the streets, I still have this mask and this little chart, and that's been with me since the day I first came a paramedic. It's not that I need that reminder, but the reminder is when you're doing a report and you're like, I had him on 8 liters, but I had it. Whoa, that's not what I'm supposed to do, and you need to make sure you check yourself. So that little chart's been very helpful to me over time. This is the last one we're going to go over. So an epi auto injector. Has anybody ever had to use one of these auto injectors, specifically epi or anything like that? All right,
No.
so your epi injector, you can give it to allergic reactions, obviously respiratory distress. Um, Actually, guys, on this one, I use an auto injector once a month for my migraine medications. It's the same exact thing as the epi injector because they're all auto injectors. My mom, before she passed, was very, very, very allergic to seafood, and I remember multiple times having to give it to her due to a reaction or counter inaction with it. And they do leave bruises. A lot of these epi injectors, I speak specifically to my mom. She every time we would give it to her in her leg, and the next day she'd have a big old bruise. And obviously it's from, you know, the trauma, and I'll call it small trauma to the leg from that auto injector. But be ready for a an impact when it hits. It's that spring's pretty strong, so it'll kind of startle you if you've never used it before. But you want to make sure to give the medication as fast as you can, as soon as you can, and to the right patient. If it's theirs, you can use it. If it's yours and you know that they're having an allergic reaction to something, you can give it to them, but make sure you document correctly on the particular process on how to do it. What are some of the actions that you're expected to see from an auto injector? Anybody want to guess?
You mean like breathing status?
Yeah, that's one. How about that? Anybody see that when they were looking for the answers?
It stops the airway from closing.
Correct. So it's
It, it slows it down.
well, so it dilates the lung. So it's gonna open it up, but it's creating a block to the receptors that's creating the antagonist respiratory distress. That makes a little bit sense there. I know it's clear as mud if a lot of y'all understand. So you're gonna expect the epi is gonna increase the heart rate. Now we're not saying they're gonna go from 90 to like 200. They're not gonna go, out the roof. But you're gonna notice that the blood pressure is from the same thing because of the increased blood pressure and increased pulse rate. You're gonna have an increased blood pressure rate. One is because they're having to work harder. There's a reason why you gave that medication through an auto injector, so expect that. Um, Document that through your assessment. Um, like we just went over, it decreases the muscle tone in the bronchial tree, it dilates the passages in the lung, and it constricts the blood vessels. So if you give this, listen to them through your stethoscope prior to giving it, and listen to them post giving it. It'll give you some really good ideas and tools of how it works and how it helps the body. Um, we just talked about the increased heart rate, so you're going to have some tachycardia, maybe some chest palpitations. I haven't had any patients ever come across that. Maybe some angina, headaches, nausea, vomiting, dizziness, hypertension, nervousness, anxiety. I'll leave the nervousness and anxiety due to the potential respiratory distress, and they think they're going to die. So that's where they're going to have the anxiety come out. Um, Hypertension is also because of the blood pressure. So you may see that once you start giving the epi, and that's the majority of the whys because it's going to increase. You're going to have borderline tachycardia. I'm not going to say you're going to be in supraventricular tachycardia as an SVT rate, but think about that. The headache may be caused from the release of the epi into the body. Can't really say that my mom's ever complained of that when she was still around, so that may be something that you see. Um, Here's some precautions. Do y'all have any other ones that y'all came up with when y'all are looking about precautions?
Could it possibly be the giving, or make sure that's the appropriate size for adult versus peds?
Correct. Some of these, here, look, I'll show you. That gives you a little bit better answer right there. You want to make sure that the dosages is set correctly. You don't want to use mom's EpiPen on her 7-year-old daughter because she's having an allergic reaction. because they're going to be metered different. And the reason why I say metered is they're going to be the same exact size. It's just the EpiPens are dosed different. Versus 0.3 milligrams, you may get 0.15. So yeah, it's a little different, but the release of it in quantity is the problem that we're looking into. You're still going to want to contact med control on all of them. Mary's asking, has there ever been a time EpiPen did not work? I'll go back to my mom. Again, yes, that's the reason why I got into being a paramedic. Is I remember when I was a young kid, many moons ago. No, but I remember when she had a reaction and she went to respiratory arrest. She coded right there in front of us, and my dad performed CPR. Paramedics showed up, tubed her right there on the spot. And before she left, I remember her reaching out, grabbing my hand. He sedated her enough to where she squeezed my hand. But yes, Mary, there have been times that the EpiPen has just not been there in time, so it hasn't relaxed the muscle tree. I mean the respiratory tree for that to take place. Um, she You're going to get to sometimes it's going to be a little late, or unfortunately that patient can't afford the epi when they need it, or just the response of the EMS was not in time. So yeah, there is some particular times that it's not going to work. When you do the administration, check the medicine, make sure it hasn't been exposed to the sun and hasn't been left in the car for 35 days. Make sure it's the patient's medication. If you're giving if you're giving the medication to the patients. So outdated, that's a good question there. So there's a recommended date dosage. Some of the Food Drug Administration has allowed certain medications to be given past the time of date. If y'all ever heard of the national stockpile of medication that's out there, the last restock that I can remember when I was messing with it was in 2018. They replaced all the medications in the national stockpile. They were supposed to replace them every 2 years. I know that they did not replace them in 2020 due to COVID. So there is a letter out there for them to extend that medication by 1 year. If you guys remember when Epi became a real big shortage on the ambulances and they were having trouble get it, instead of doing single dose, we went to multi-dose vials, and we were able to use those past the recorded dates. I will tell you, if I show up there and I'm maybe a lay person and I'm not working anywhere and they have a EpiPen that's out of date, I'm really just going to give it to them anyway. They need the medication that's in there. We didn't withhold any medication from them. We gave them the medication that was this theirs. So just remember that. The best place to give it, midway between the waist and the knee, right in the thigh. Pick a good spot. Look at it. The needles are big enough. You don't have to expose the skin. It'll go through the pants, shorts, whatever. Not necessarily saying, oh, you can't give it until you find some alcohol to clean the area. No, don't withhold the medicine from them. But push it firmly against the leg. You don't have to try to jab it into their leg, because as soon as you push the dispense button on the top, oh no, it's gonna come through. So you have to, but you just don't want to lightly touch it against the leg. Put some force behind it, and just hold it in place. You'll hear a click initially, and a click when it's done. Hold it in place for maybe another 2-3 seconds, and then pull away. I can tell you over some personal experience, once the area has been, I'll do it for my migraine shots too, and just rub the area. Rub it, I'll say forcefully, but again, just remember you're trying to rub the medication into the body. So put some umping behind it, but if you get it into the body really good, you'll be fine. And then once you give the medication to the way it's supposed to be, you're going to be good there. And then the auto injector, you want to properly dispose of it. The needle will retract back into it, but it doesn't mean that it can potentially come back out if the spring's broken or some of that factor. But don't just throw it in your purse and be like, oh, I can throw away this later, or in your book bag or something like that. No, you want to make sure if the ambulance is going to transport that patient, give it to them and let them going to take that patient, take it with them. So that's it. Does anybody here tonight anything have any questions? Y'all want to talk about anything? Go over something that we went over? Anything? It's up to y'all. Y'all let me know. All right, folks. Well, I'm not gonna say two of y'all speak for the total 21 people in the class, but if I don't hear anything, I don't see nothing down below in the chat. Victoria already told you you're not getting the code. I can give it to everybody else. So the code I'm gonna type into the chat. This is not for Victoria. I don't know why my messaging's not allowing me to chat. Everybody. Y'all give me just a second and figure out why this is not working. I'm gonna turn my screen sharing. There we go. Now we can type it. All right, so here's your code. It is capital E9, M as in Mary, 1, S as in Sam, and 1. You kind of get the funny behind that? Come on, somebody tell me they got it. Mary, appreciate you. Appreciate your comments. Hope that you got something out of it. I hope, Mac, I appreciate you too. The other ones that have spoke up and talked, thank you guys so much. Please feel free to message anytime on Facebook if you have any questions. I will be traveling tomorrow morning back to shore. So if for some odd reason you guys hit me up before 1 o'clock, anything on Facebook or nothing like that, I will probably be on radio silence because of the flying in on the helicopter. But all else fails, I say hear from you guys on Wednesday, but I will talk to you guys again Wednesday. And after Wednesday, we'll be going to the Tuesday, Thursday. If y'all saw the message on the Facebook a little while ago, Rob, that he's updated everything to start Tuesday, Thursday on the 9th and the 11th. Thank you, everybody. Again, thanks, Mary. Y'all do have a safe night. Be careful. I'm going to shut up and let y'all have a good night. Y'all be careful. Good night.